I'll do that now, actually, so then I know what I'm doing.
Do you want it all visible for introductions or turn them off?
Why don't I introduce you one at a time?
Okay. Okay.
Is that okay, Elizabeth?
Yeah, super. Thank you.
Okay. Elizabeth, and also just going through my checklist here, the evaluation, what are you going to email that to everyone?
I am, yeah.
Okay.
I've got it set up to send out straight after the webinar.
And what about the hashtag there? It's a bit of a tricky one. Is that because it's all case sensitive, isn't it?
Yeah. That might be better if we make it all caps, maybe. Do you think?
Liverpool STOP COVID. Is that the official one?
As far as I know, yeah.
Okay. Leave that to you.
You. We've got the registers set up for the September webinar as well. So I've added that to the email for the evaluation so people can register today for September if they want to.
Okay. Right, so I'm ready when everybody else is ready.
Yeah, should make a start.
So Jerry, you got your lipstick on? Yeah.
He's done more than I have if he has.
He dyed his hair this morning, Sue, don't worry. At least he's not wearing his cycling top. And you're muted, Jerry.
Good job.
Yeah. Yeah, he did a good job. You got all those smokies out.
So I was just going to try and improve the quality of the audio a bit. There we go.
Elizabeth, I'm ready when you are.
Yes, we can make a start now, William.
Okay. All right. All right. So good afternoon, everybody. It's 3 minutes past the hour. My name is William Hope. I'm leading Liverpool STOP COVID response, and welcome to the third of our seminars. This is the final seminar before the so-called summer break. The next seminar will be on the 25th of September at midday. We've had over 300 people register for these seminars. They've been a fantastic success from right across the city. We will be in touch soon with the registration details for the next seminar. This seminar is being recorded and can be distributed for those of you who are interested or have people that haven't been able to make this live stream. Q&A is an important part of this, and we have deliberately tried to control the agenda today so that you can ask questions. You need to do that via the chat function, and we'll be monitoring that, and we'll put your questions to the speakers at the end of the session. Elizabeth will email an evaluation for you, and of course this is for our community, so we can shape these seminars based on the feedback that we get, so please fill those in. There's a hashtag Liverpool with a capital L, and then STOP COVID, all in capitals, if you would like to tweet about today's seminar. Okay, so with the introduction done, it's my pleasure to introduce Professor Jerry Davies, who is the local lead for infectious diseases at the LCRN and is responsible for implementing clinical studies that are badged as urgent public health priority. in our region. This has been a fantastic success for our city and region. And Jerry, over to you. Thank you.
Thanks, William. So may I say it's a pleasure to be invited to talk about this subject today. And as you alluded to, this has been a tremendous challenge for us and something with which we've had some success, which we'd like to share. I should say, I'm giving this talk really on behalf of a group of specialty leads in the Clinical Research Network, which takes responsibility for NHS research in the whole of the Northwest region, not just in Liverpool. And I think it will be no surprise to anyone watching to learn that really the north of England has been among the regions that have been most badly affected by the COVID-19 pandemic. And in particular, here in the Northwest, the cumulative incidence rate of infection is in fact the highest in the country. And by comparison with some other parts of the country, such as London or the Southeast, the absolute number of cases has been perhaps 25 or 30% higher than elsewhere. So this has been a massive challenge for NHS services and for all of our communities. But looking at it from a research perspective, it's been quite as much of a challenge. And in fact, what has happened is that there's been a complete redirection of the NHS CRN portfolio of studies towards COVID research. Really, the system pivoted on a small coin to shut down almost any other kind of research within ethical considerations, to devote itself entirely to studies on COVID-19. And in particular, some of them you may have heard about, but we'll touch on those in turn. But there are now 50 studies on this so-called urgent public health portfolio, supported by the CRN, to which more than 135,000 people have been recruited as of today. And among those studies are some which have been particularly newsworthy, and importantly, studies which are what we call platform studies, studies which are designed to be adaptive in nature, that is to change during the period of the research, to take on new drugs, to eliminate drugs which are manifestly ineffective, and to persist throughout the period of the pandemic. And among those, of course, are the recovery trial, which discovered the importance of dexamethasone and the non-utility of hydroxychloroquine. REMAP-CAP, which is a similar platform trial looking at patients in the ITU in secondary care. The PRIEST study, which is a study of triage systems and identification of severity of disease in MAUs. The ISRIC 4C Consortium, the Clinical Characterization Protocol, which is the highest recruiting study amongst all on the portfolio. The COVID-19 Oxford vaccine trial, which has been especially newsworthy, and the Accord platform for early phase trials of novel therapeutics across the country. So the complete change, the ability of the NHS CRN to pivot towards this kind of research, I think, has been nationally for us in the UK a huge success, and really, to me, has realised the potential of the NHS CRN to be able to take on research of this nature, which would be very difficult in some other countries and with some other systems of research support. That has mandated as I said, a near complete cessation initially of non-COVID research, and that has continued for the last 4 months, with some obviously continuing consequences for non-COVID research everywhere in the UK, and the difficulties that we're having with restarting research in different research sites. And that's been very, very variable across the Northwest, as it has in other parts of the UK. But essentially, even as of July, as of last week, you can see that considerably more than 50% of studies are still paused. So to move on to our response to this big challenge, the central challenge of the UPH portfolio was that this was a nationally dictated list of studies that we were being expected to implement in the Northwest. And so it was very clear that that process needed to be carefully managed in terms of maximizing research capacity and capability, and also avoiding important conflicts between studies at individual sites. So at the very outset of the pandemic, our local CRN convened an urgent public health working group, which was chaired by me, that comprised all of the relevant specialty leads, including respiratory medicine, intensive care and primary care, and so on. And also co-opted representatives from important sites, research sites in every part of the network, and the clinical research facilities, which are also supported by NIHR. We were also supported very ably in that by the research and data managers from the core CRN team to discharge our essential function, which was really to review the impact of these studies on the CRN portfolio, whether they posed any conflicts, whether they could be implemented in all sites or just in a few, and to make some advisory recommendations to sites about which sites, which studies were of the highest priority and which we felt they should proceed with first. So there was a constant monitoring really of expressions of interest and intelligence that we received from contacts on national committees about the progress of this portfolio, which happened very rapidly over a period of just a few weeks, from naught to more than 40 studies in about a period of 4 to 6 weeks, which is pretty unprecedented for CRN, for normal CRN processes. And I think it's important just to mention amongst some of those conflicts, the national process did not really sort all of those out. And so locally we were faced with some conflicts between different platform studies for phase 2 trials, and also conflicts between epidemiological and serological studies and new interventional studies of vaccines which have appeared within the last couple of months. So those conflicts and that need to manage the resource was very real. How did we do that? Well, as with other complex administrative tasks, it largely came down to a spreadsheet. We convened a weekly meeting of all the people that I mentioned to prioritize and to triage all of these studies with a simple red, amber, green kind of system, and with some detailed scientific and feasibility comments to the sites to help them to identify the priority studies and to set them up and to recruit to them as quickly as possible. What was the result of that process? Well, for those who are familiar with the Northwest CRN, it's important to say at the outset that our performance nationally has usually been in the lower half of the 18 sites across all of the regions of England and the devolved nations and Northern Ireland. So we usually lie somewhere in the sort of 12th position out of 18. But during the period of COVID, essentially what has happened is that the research, access to research studies and the ability to recruit to them has largely been leveled. And it's now a very different sort of playing field to how it was in terms of the research disparities in the UK to what it was prior to COVID-19. And interestingly, that has resulted in our performance greatly improving by national standards. In fact, during this period, we have been either 4th, 5th or 6th nationally by comparison with others. And so we've moved from the bottom tertile into the top tertile in terms of performance as a CRN. And that's been driven really by every part of the region. If you look on the right there, you can see that all of our major acute trusts have been involved in this kind of research. Looking at these with national comparators, if you take, for instance, the Royal in Liverpool and University Hospital Aintree, which of course are now a single trust, their performance in terms of recruitment is amongst the best nationally in terms of research sites. So that change in our and the total number of participants that we've recruited out of those 135,000 is slightly short of 8,000 currently. So there's been a major turnaround and really a step change in our research performance during what really has been an unprecedented challenge. And I'd like also to mention a couple of particular successes from a Liverpool perspective. I know that you've heard about at least one of these on a previous occasion, But I will just mention the centrality of Liverpool investigators in the clinical characterization protocol. As I said, the highest recruiting study in the country. It's essentially a simple observational study and means of sample collection for to support a platform of other investigations into the nature of COVID-19 and diagnosis and treatment. And Liverpool has played the role of being the central repository for samples in that study, and as you can see here, is at the centre of the ISRIC universe from that perspective. As for the COVID-19 vaccine trial from Oxford's COVE-002, investigators at LSTM and the team there have been instrumental in a very strong performance in recruiting more than 600 patients to that trial, which is in fact within the phase 2b/3 phase of that study, the best performance nationally, better in fact than Oxford itself, although the figures there reflect the fact that many of the earlier phases of the research were conducted only in Oxford. So some major highlights for us nationally, as well as the overall improvement in our performance. So what lessons do we draw from that? Well, as I said, this has really represented a massive step change in our ability to deliver research. And what we've discovered is that really our setup and recruitment capabilities are as good as anyone else's, and certainly nationally competitive. It has been, I think, very important that we've had this locally coordinated approach that's enabled us to make the best use of the resources that we have in the different parts of the CRN. And we have seen several new models of local partnership emerge during this period. In particular, I'd mention the approach that was taken by Liverpool Health Partners to creating a healthcare worker platform for studies that focus mostly on healthcare workers. The collaboration between the three clinical research units in Blackpool, Preston and in Liverpool on the phase 2 studies, and also a kind of nascent collaboration around forming hubs for supporting large-scale vaccine studies. We've also felt the need at times to spread the load and to find new principal investigators and chief investigators who could contribute to supporting these studies. And we've also seen some bottlenecks in support for preparation and dispatch of investigational medical products for particular trials. The landscape has been very, very complicated, lots of studies with many different kinds of arms, all sorts of different drugs and vaccines that have needed to be prepared and delivered by pharmacies across the CRN. That's proved to be a big challenge. So what does the future hold for us? I think we hope that this change in the performance of the CRN is something that we can sustain, and that we can use the lessons that we've learned during COVID-19 to do what we do better. But of course, there is a lot of uncertainty currently around what is going to happen next. And for the past month, I think everybody has been watching anxiously the epidemic curve, which you can see there, to see whether in fact there is any evidence of an emerging second wave of infections. And hence there's been quite a lot of reticence amongst sites and CRNs across the country about reopening non-COVID research, even though the COVID-19 platform studies of various sorts are still open. Even though they're not recruiting many patients at the moment, they remain open with a view to continuing to enroll patients if there is a second wave. And the other challenge we have is that because even though there are not many, fortunately now, many people sick with COVID-19 in our secondary care facilities, the race is now on to create a vaccine which will enable the world to emerge from the lockdown that it's currently in relating to the pandemic. And generating capacity for studies of this size, we estimate that we may have to recruit anything up to 1,000 patients a month across the CRN to support multiple vaccine studies of this kind, is challenging us to think outside the box and to use resources beyond simply the CRN itself, and to collaborate more creatively with local authorities and other partners who can help us to deliver those kind of studies at that sort of scale. So just to finish, I'll just emphasize again, we think that our response within the Northwest CRN to the COVID-19 pandemic was pretty proactive, and overall has been a success. We saw that the pandemic really strengthened some pre-existing mechanisms of partnership, particularly within Liverpool, but also across the CRN as a whole. And there were notable improvements, both in research setup times and delivery in terms of recruitment numbers. So the challenge for us now is really to try to build on that collaborative response under peacetime conditions when, if ever, things are more normal than they are now. But the biggest short-term challenge really is to balance the needs of reopening the non-COVID-19 portfolio with the need to support these large-scale vaccine studies. And in the longer term, to begin to take ownership back of the portfolio for ourselves and to promote locally relevant and led research, particularly in infectious diseases. So that's all I have to say. If there are questions on the chat, I'll be very happy to try and answer them.
Thank you, Jerry. Yeah, so that is a reminder to everybody to send your questions to Jerry and all of the subsequent speakers on the chat. I can't see any there at the moment, but I have a few for you later on, Jerry. So thank you. So I think we might move on, and my pleasure to invite Lucy Frith from the Northwest Coast ARC. Lucy, are you ready to go? And I think you're going to share your screen.
Yep.
Welcome, Lucy. Thank you.
All right. Can everyone see my screen?
It's all good.
Is that okay?
Yes, thank you.
Okay, marvellous. Hello, well, thank you very much for giving us the opportunity to present our research that we're doing in the Northwest Coast Applied Research Collaboration. And we thought that it'd be useful, before giving you a whistle-stop tour of the kind of work that we've been doing since March, was just to give people who may not be familiar with the ARCs and our ARC in particular, a little bit of an overview of what they actually are. So the ARC is, as I said, the Applied Research Collaboration, and we are the Northwest Coast ARC. I am the Public Involvement Strategic Lead, so I'm presenting this on behalf of my colleagues from the ARCs. So the ARCs were established last October, which now seems an awfully long time ago in a very different environment. And they were an evolution of the Clerks, which were a very similar type of body, but they were collaborations for health research. And the ARCs are very much on the applied implementation end of the health research trajectory. So there was approximately £135 million invested by the NIHR in these. And the aim was to tackle key issues facing our health system, including the pressures of ageing populations and increasing demands on the NHS. So our ARC is hosted by Liverpool CCG, but our footprint is actually the Northwest Coast region. So we're not just a Liverpool-based organisation, we encompass the universities of Lancaster and UPlan. So, sorry. So as you can see, the Northwest Coast ARC has a focus on health inequalities, and it's interesting that, as was highlighted in the previous presentation, the COVID rates have also been some of the highest in the country. And our key focus is looking at these health inequalities, particularly focusing on ageing, multimorbidity, and the consequent demands this places on the NHS. So our ARC provides national leadership on some of these key areas, but with a very clear focus on health inequalities. And without going into this slide in too much detail, you can see that by many indicators, the Northwest is an area of quite significant health inequalities. So That's one reason for focusing on that, but we also have a lot of expertise and world-renowned researchers in this area, so that was also a reason for choosing this as our focus. So the ARC is essentially a collaboration between various types of organisation, and we began developing the ARC out of our previous clerk by very detailed consultation with our stakeholders, and this is a pictorial representation of that which hangs in our office. It's quite a big poster, you can't really see the details. But we did a lot of consultation to see what our local members needed from our ARC. So, as I said, our work impacts the North West Coast region, not just our individual organisations, and we have over 60 partners that include NHS, local authorities, third sector organisations, and very importantly, a cohort of public advisors, and we have approximately about 60 public advisors who are members of our forum and contribute very much to our work. The universities act as coordinating hubs, as I said, Lancaster, UCLan and the University of Liverpool, and we have matched partner funding in addition to the grant in the region of £9 million. So essentially we facilitate collaboration between members. We perform research, evaluation and capacity building activities with them. So when we say we, the ARC is very much made up of all our members, and seeing this as a community is very much how we hope to build our success. So that's just some background on what the ARC is and our particular focus on health inequalities. And I'll just give you a very broad overview of the projects that we've started since COVID-19. This is a rather busy slide, but I presume you'll be getting these slides, and I'll also give you the web address to follow these up. So we've had a survey of optometrists, and we've also been very involved in the University of Liverpool funded COVID research. And we're involved in a numbers of those areas. So we're involved in the COVID Live cohort study, the psychological and social impacts. We're involved in the understanding choice and control and risk in the community, and that's across Malawi and Cameroon as well. So we've got some global health input into this. We've also, I'm co-leading what's called Area D, which is the impact of COVID on the distortion of healthcare systems. And that is a collaboration between the Tropical School and sites in West Africa, Liberia, particularly to look at how we can prepare and make health systems more resilient for future epidemics. We've also got work involving the BME community in Liverpool, and one of those was a study on the Muslim community's experiences of COVID. And then we've got a tranche of work around public involvement, which has been an issue during COVID for research. We've got a project that I'm leading on remote working practices for public involvement, and seeing how people have adapted to working remotely, but also how we can build capacity in this and how we can explore this as a way of mitigating rather than entrenching health inequalities. So ensuring that people have good access to participate in research, because the Health Research Authority reported that public involvement in studies have decreased since COVID, and that is obviously a problem. We've got studies, there's quite a big study led by Dr. Gable on the impact of COVID on social care and the lives of people with dementia and family. And we're also developing work on healthcare professionals and patients' views of remote primary care consultations, which is again a very important area. And part of our public involvement work is also piloting diary methods to capture their experiences of the impact on COVID on communities. So again, don't want to go through each of these, but you can see we're doing work on staff training and service evaluation, analysis of excess mortality, and the effects of COVID transmission on hospital demand. And finally, we've got a project in development looking at both blue and green spaces and how we can help people increase their well-being by using this in a time when certainly some communities find it very hard to access outside space. So we've also done systematic reviews. One of our arms is an implementation arm and a reviewing. We've done 7 systematic reviews, some of which our members have requested directly. And this is a list of some of our publications so far. So that's just some more information that you can follow up later. And just to conclude, we've got a Twitter account, obviously a website, but our COVID research updates are posted regularly on the ARC website, so you can go and have a look at those for more details about our projects. And also, if you're a member organisation or want to become involved in our work, then please contact us at the above email, so you can get a flavour of the kind of work and the areas we're interested in from the presentation. So thank you very much for your time, and please put any questions in the chat function.
Thank you, Lucy. Actually, there are some questions in the chat function that you can think about as after we've heard from Sue. So Sue Dowling is from the LCRN, and there are no slides for Sue. Rather, there's an interview with LHP, so with Elizabeth. So over to you, Sue and Elizabeth.
Hi everyone. I was asked to give a little presentation today about the Oxford vaccination study and in particular a participant's experience. So approached Liz. So we've got some questions that I'm going to ask Liz, and she's going to explain about what she experienced during her participation in the Oxford vaccination study. First question for you, Liz. Why did you want to take part?
Well, there's 2 parts to the answer there. So the first part is, unfortunately, I'm not clever or talented enough to the clinical or the scientific effort against COVID. So that's very sad. But I don't think I'm alone during the pandemic in recognising my huge privilege in terms of living in a country where we've got access to clean running water and soap. I live somewhere that's safe, you know, I've got access to towels and tissues. And for someone like me, following the public health advice around COVID was really very straightforward. I'm also very lucky to enjoy good health and be well nourished, better nourished than ever since lockdown, a bit more generously proportioned than I was. But being in this very privileged position when, you know, internationally and in the UK and here in the city of Liverpool, people were, you know, very, very poorly and dying, I really felt that I wanted to do something in some small way that might be able to help us learn more in the fight against COVID. So really that was my motivation for taking part in the study.
That's great. Thank you very much for that, Liz. So my next question is, how did you find the registration process? Because I know it was, you had to do it online, and I don't know whether some people had issues with the link or anything like that. I just wondered how you experienced it, really.
For me, it was really straightforward. I couldn't believe how slick it all was. So I completed an online form on the Friday. I got a follow-up telephone call on the Sunday, and then I was booked in for my first appointment for enrolment the following Tuesday. So it was just so efficient. And
oh, great.
It was very good.
Yeah. It was very manic in the background, I can let you know that. So did you have any concerns or worries about being involved? And if so, how did we address those for you?
I mean, as I say, I consider myself very fortunate in terms of my health, and very luckily for me, there was nothing about me or my health that meant that I was high risk in terms of COVID. But anyone who knows me will tell you that I am so risk averse. So, I've never tried smoking, I've hardly drink, fanatical about brushing and flossing my teeth. I'm naturally a very cautious person. So as you can imagine, I did pay attention to the potential side effects. But as I said earlier, part of my motivation for being involved was around me thinking about how fortunate I've been. And of course, I've got a choice about whether or not I participate in the study. For the people who've been very poorly and sadly passed away, they've had so little choice. So once I took that into account, that really made my perspective think about the bigger picture. And of course, in terms of the registration, as I said, that was just so efficient. I thought, this is another level in terms of how well these people are working together. So that gave me some confidence. And then in terms of the information that participants were provided with at the enrolment visit, there was a lot of really helpful material, and it was provided in a few different ways. So that attention to detail, it meant that I felt, people had really thought about what this meant for participants, and that was very reassuring.
Oh, that's good. That's really good. So what happened at your enrolment visit then?
So it was a lovely start, because I was greeted at the Accelerator building by one of the lovely ambassadors who were the volunteers for the study. And we had to show our ID, so it was very security conscious. So, we were who we said we were. And then we were shown into a physically distanced waiting room. And I could see immediately how much thought had gone into this process, because obviously the seats were set out in a certain way, and there was very supportive information all around. So that was really helpful from the very start. And from there, we had our first meeting with the doctor, and we were asked questions about our general health, medication, and so on. And then we were taken into another room to watch an information video, and we were given some documents to read as well. Now, a doctor came to see us physically after that to ask if we had any questions. So again, it was all really reassuring. There were so many opportunities to ask questions. And from there, we then went into another room to see the nurses. So we had our blood pressure done, our samples taken, our weight, our height, and of course we were consented there as well.
Oh, great. So that, I know the organisation of all that, I can't take credit for at all. It was all done by the LSTM team, and it was very, very slick, I have to admit. So just let me find my next question. 1 second. Can you let us know what you found? I know you've said it was very slick, but what was the good things about that experience? What did you find that was good about it?
So, as I said, that attention to detail was very reassuring from a participant's perspective. And, you just, even without being somebody who's got a scientific background, that pulling together a complex process like this so quickly, it requires a lot of effort. And yet so much energy had clearly gone into getting the communication and the information right. I mean, right down to, we were given advice about using social media, about our participation in the study. So I felt like my participation was really valued. The nurses were so kind. So as I've mentioned, weight's been a bit of an issue for me during lockdown. Trousers are really tight. When it came to weighing me, I really didn't know the numbers on the scale, and they were so indulgent and kind. They didn't roll their eyes or anything. They just noted it discreetly, didn't say anything. So it was all those social interactions and all those kindnesses just really added up. As I said, the ambassadors were very positive and enthusiastic, and overall the atmosphere was just lovely. And it was hard to believe that this was a team that hadn't been together all that long.
No, some of us have never worked with one another before, but we just gelled so well together. I know there was a couple of comments from participants saying what a nice atmosphere it was when they came in there, and you know, everybody seemed to know what they were doing and everybody was working well together. And personally, I found it a really rewarding experience to work on in that team, and be part of something so big. Really, it was us doing our bit, if you like, and helping to, you know, bring all this to an end, fingers crossed soon.
Exactly.
So would you change anything at all about any of your experience? I mean, honest feedback here, you know, it's really valuable, because we've got the next phase that we're going to be doing in a couple of weeks' time. So if feedback about changing anything would be really valuable, really.
Well, I've got to say, Sue, I'm a self-confessed nitpicker, fanatical of details and improvement. And I used to work as an NHS complaints manager many years ago, and I've never quite been able to switch off that critical eye. But with this study, there is nothing I would change.
Really?
The effort was exceptional. It was a really positive experience from start to finish.
Oh, that's amazing. Thank you very much for that, Elizabeth. So you went for your screening visit, and then you had your vaccination visit. So how did that go?
So the vaccination visit was 2 weeks later at Liverpool School of Tropical Medicine. Again, you know, greeted really cheerfully. There was car parking set aside for us, so we didn't have to travel on public transport. We showed our ID again, and then we went through the same health checks that we'd been through previously, and we were consented again by the nurses. We had a repeat visit with the doctor to go through that information. And then we were taken to a clinical room for the vaccinations. So that was very pleasant, because we got laid down on the bed to take the bloods and to receive the vaccination. And then we had another nice lie down for 30 minutes, which was very pleasant, to check that I was okay, and I was absolutely fine. And then we were taken into a final waiting room to just have a drink and sit down, and just to check that everything was okay.
Fab. And how have you been since?
I've been great. I've had no side effects whatsoever.
Fabulous. Fabulous. Now, did you have to do your swabs yourself? Because I know that was one of the things. So how did you find that experience, having to do that for yourself? And what, I had nothing to do with that side of the study, so I don't know what the process was for when you'd taken the swabs and things. What did you need to do?
So, I mean, that was absolutely fine as well. We have to do the swabs weekly, mine are on Tuesdays, and everything was packaged up for us to make it easy. So we just got a separate package for each week. And I just have an alarm on my phone just to remind me to do it. We were also given a brief when we went to that final waiting room for a drink before we left. We had one-to-one brief with a nurse that was there to talk us through how to do the swabs properly. So there's no excuse for just wafting it around in the general vicinity. She was very clear about how far down it had to go into your throat and into your nose to get the proper results. So it was very supportive indeed.
Oh, I'm glad. And what advice would you give to somebody who's thinking of taking part in a study like this? Because I know that this was our first experience of doing anything vaccination-wise for COVID-19. And the setup process, it was done very, very quickly, because we didn't have a lot of time, and we knew that we were, you know, had to get this done by a certain date. And we're going to have to do it again soon, because we've got more vaccination studies coming through as we speak. So what advice would you give to somebody who is thinking about taking part?
I think I would say think carefully, because it is a commitment, and it's not just a case of turning up on the day. It is a longer term commitment. But I would say for me, it's been such a positive experience, and in a number of ways that I hadn't anticipated it would be positive. And I think for somebody who is organising a study, I would advise looking at the study that I was part of as an example of good practice from the participant perspective. As I said, the science is completely beyond me, so I can only say from the participant perspective, it was really positive. So I would encourage colleagues who are organising studies to certainly look at this experience.
Oh, so having gone through it all, would you do it again?
Yeah, I definitely would.
Oh, that's brilliant. Do you know, one of the reasons why personally I do, the job that I do is to give patients a good experience when it comes to research, because I feel, you know, people go above and beyond. They don't have to be involved in a research study. So for us to give them a good experience is the least we can do. And the fact that we've had such good feedback from quite a few people about about this research study has made it even more worthwhile doing. So thank you very much for your feedback, Elizabeth. It really is really appreciated. And I've been to see the team again this morning, so I'm going to feed that back again to them later on when I go back, to just let them know just how much you've found it such a rewarding experience. So thanks very much for that. Yeah.
Thank you.
Oh, and that's us, I think. That's our little bit done, our little interview.
So, actually, so while you're both there, let's go in reverse order then. So so actually Alan Griffiths has put a question just in the chat, just as I was about to ask my question. It says, can someone who is shielding apply? So Alan raises a good point about vulnerable groups who might need the vaccine more than anybody else, elderly patients, immunocompromised patients, some reason. How would they access this system?
I think I've just lost you.
Elizabeth, can you hear that?
I can hear the question. I can answer the question for you if you like.
Okay.
So the participants who were involved in the study needed to be healthcare workers. So they needed to be healthcare workers who weren't shielding as such, because they were going to be in an environment where they were going to be with other people. And although we did, go beyond the ends of the earth to make sure that social distancing was adhered to, that risk would still be there. So, and once the vaccinations are out and about, I'm sure there will be appointments made at GP practices for people who are vulnerable and need to be shielded and can't go into contact with other people. We were quite open about the fact that, you're going to be with other people, and if you're shielding, then you can't be involved in this research study. That doesn't mean that you're not going to be able to be involved in any vaccine studies in the future. It depends on the setting, I suppose. So if there's a vaccination study that's set in primary care or in the community setting where they can do home visits and things like that, then I'm sure they'll be looking for people who are in those vulnerable groups. But for this study, it's basically to see if it works or not. So it's for what we wanted from the participants is for those to be in contact with people who may have COVID-19. So it was for healthcare workers because they're more prone to be involved in to come in contact with people who've got COVID-19. So if you're shielding, you wouldn't have been allowed to be in this research study because you're not going to be in contact with anybody, let alone anybody with COVID-19. So for this study, no, but that doesn't mean you're not going to be able to be involved in one in the future, depending on what the protocol and the endpoints are for that study.
Yeah, so let me also just help answer that question, Alan. This so Liverpool and the Northwest Coast is just in the middle of trying to design its program about how to deliver sort of up to 10 to 12 vaccine studies to something like 10 to 12,000 people. And the majority of that we anticipate will be through very high throughput centers. But in response to your question, I think what we're also going to design is some mobile units to get out to variably called hard to reach populations, and so that might be people that are shielding, or NIHR is now calling underserved communities. So these might be homeless people, it might be asylum seekers, it might be the elderly in nursing homes, it might be people, as you say, that might be shielding. So we're going to have to design a bespoke system to get out to people. It's unsafe to bring them, as Sue was saying, into a large group of a large centre. So hence the paradox. So thank you, Alan. So thank you for that question. Right. So, well, actually, we have a little time. So Sue, I'm going to ask you.
Yeah.
So Elizabeth, pretty happy with her experience. We know that the study that you ran was relatively, even though it was enormous from the size of clinical studies we ordinarily do and incredibly intensive, there's another order of magnitude now to go. So what lessons to go from 600 patients to 12,000 patients?
Ooh,
Are you going to be able to keep Elizabeth happy?
I would hope so. I mean, nobody sets out to give anybody a bad experience when they come into any kind of medical profession. Do you know what I mean? And it's not something that you set out to do. So with that in mind, making sure that everybody knows what every member of staff who's working on the study knows what the role is, and knowing what is expected of them is really important, because that reduces their stress levels, which means that that's not passed on to the participants. So for me, it's making sure that the people working on the study are comfortable with what they're doing, and making sure that they're not getting too stressed, which can be difficult when you're trying to get that many people through a process. So I think manpower has got to be one of the biggest things that we would be looking at, really, to support this study. I mean, at one point, I think there was 70 doctors supporting the LSTM study, which was immense, but you can't sustain that. So it's looking at how you are going to get people to support the study, enough people to support the study. That's going to be the biggest issue for us. And I think if you can achieve that, then, you know, participants, you know, I'm not saying everybody had a fantastic experience. We had a couple of people who couldn't wait because they'd been waiting quite a while, and, you know, through no fault from ours, it was one of those things, and so they couldn't wait any longer, or people were complaining that actually they'd been around for 2 hours when the appointment was. We had told them it was going to be 2.5 hours, but, you know, they couldn't hang around. So it's being upfront with the participants, I think, is a main thing as well. So you've got to make sure that you're honest and you're open with your participants to give them a good experience, and making sure that the people working on it know what they're doing and are happy to do what they're doing, and you've got enough of them. Okay,
great, thanks. So just as a final comment from me, is that anybody on this call that's also participated in the vaccine studies, if you'd like to come forward and do what Elizabeth did, so we can use this as a communication tool, because we're going to have to enroll not 600 people, but 12,000 people, please get in touch with us. I think that you started saying, Sue, that this is probably the largest challenge, healthcare challenge, that any of us are going to face in our working lifetimes.
Oh, definitely.
This vaccine problem that's coming now, this is a massive problem for our healthcare economy and sector. And well, this will be what we'll be doing until Christmas and beyond. Okay, so thank you to Sue and to Elizabeth. Now, Lucy, where are you?
Here.
So, Alan also has a question. I'm going to see if I can just paraphrase Alan's question. So, in the Northwest Coast, there's different sorts of healthcare inequalities. And so how does the ARC go about understanding and addressing those different types? Or is that a fair thing to say?
No, I think that's a completely good, fair thing to say, and a really important point. I think we try and go about addressing them by well, the research we do, and also the research that we're doing on the back of the work we do with the ARC. So I certainly know Ben Barr has recently got funding from the Health Foundation to look at different kinds of health inequalities. You'd have to ask him more specifics of that, so I'm only presenting on behalf of my colleagues. But certainly I think the different kinds of projects we've had, so particularly Shema Hassan's work on the Muslim community in Liverpool is one particular aspect that's been focused on. I saw also in the comments you mentioned, are we doing anything in Blackburn, Darwin and Pendle? And I don't know the specific answer to that. But certainly we try, and rather than seeing health inequalities as a as a whole unpick the different types and then look at the relevant kinds of interventions and services that would help and mitigate those. So we do take a nuanced view with the research we conduct.
Okay, all right. I mean, Alan, I don't know if you're still on, and if that is Lucy. Alan's question, Lucy, was really in terms of the, you know, the way that COVID-19, the pockets of COVID-19 throughout the Northwest Coast can be addressed by understanding those inequalities.
Yeah.
Yep.
Yes, and we are doing work on that, definitely.
Okay, all right. Thanks for that, Lucy. Now, Jerry, just while I get Jerry back, Vanessa has in the chat about the register. Thank you for that, Vanessa. So that's helpful. So there's going to need to be a significant communication pitch, social media, radio, television, to sort of have a dialogue with the public about the importance of understanding vaccines and participation in clinical research. So thank you for that. So Jerry, I think so now, Mark, can you put in the chat line what your surname? That would be nice to see which Mark you are. But I think the question from Mark to you is, Jerry, we're used to sort of saying the fragmentation that's in our city, the multiple different partners is the excuse for why we don't do well. So why is it that we just turned around so quickly and did such a good job? How did that just happen?
It just happened in the sense that it was spontaneous. I think there were a couple of reasons for that. So I said, didn't I, that this was a complete reset and flattening of the research playing field, right? So everybody's playing in the same division, actually recruiting to exactly the same studies, regardless of the lead CRN or where the investigators were from, because the ambition was huge. It had to be done on a UK-wide scale. So that proved to be to our advantage, I think. And within Liverpool, and in terms of the relationship between Liverpool and other parts of the CRN, I think that sense of common purpose was really critical. You know, there was only one game in town that everybody had to play. So everybody was signed up to that. That's the first thing. And then the second thing, I think, was that because of the scale of the challenge, everybody had to talk to each other. And I think, you know, certainly there was a sense that people are in a kind of ordinary, kind of everyday business. People are working in their own institution, working in different research areas, not really aware of what's going on elsewhere. That's very different during COVID. So I think people had to talk to each other, met each other, began to understand what people were doing in other research sites, and what they were doing well, and what they could learn from them. And I think that was really opened a lot of people's eyes to that communication. I think between sites was absolutely critical. And when I say then I hope that those lessons can be preserved, I think that with a bit of luck, that change in people's awareness of other people's research activities and their skills is going to be really important in terms of bringing different parts of the research system together. The challenge will be preserving that sense, I think, of kind of common purpose and destination. I mean, clearly, yes, our goal as a CRN is to deliver what you know, UK research priorities. But as I said at the end, I think it's very important for us to develop research in areas that are you know, focused on the Northwest and the health needs of the Northwest, and that are led by Northwest investigators.
All right, so focus boundaries. And for Lucy, for you and for other social science researchers out there, this seems like an important social science question to me, how a complex system like ours just pivoted around to figure out how to solve this. I mean, preserving the lessons as we move forward would seem a pretty important question to me that you would know how to actually explicitly answer rather than sort of just observing that it happens. So thanks for that, Jerry. So we're almost out of time. So Cal just has a note about the whether the phase 3 Oxford vaccine trial will be recruiting in Liverpool. So we're in the middle of designing what the regions, not just Liverpool, the regions, as in the Northwest Coast portfolio, will look like. And so, as you heard Jerry saying, there's something like 10 to 12 phase 3 vaccine studies coming. They'll be here in September. They'll be enrolling until the end of the year, and then follow up for all of next year. So the answer to your question is yes, and then some more as well. So there will be no shortage of trials to be enrolled in. And I'm not sure you know, but the nation has chosen different types of vaccines to mitigate risk, in the hope that at least one of them will be protective, or at least partially protective. So more on that soon, and more on this whole topic soon. So I think it just remains for me to say thank you to all of the attendees. I hope that you'll give us your feedback, and look forward to seeing you again in September. And especially thanks to our 3 speakers, and Elizabeth, of course, for her organisation of this seminar series in an ongoing high quality. And with that, I'll say good afternoon, and thank you very much for your attendance, and look forward to seeing you shortly. Bye-bye.